All right. Well, thank you very much for inviting me to introduce Dr. Poenaru. And I look forward to hearing about the coming age ascendancy and persistent threats, and more about pediatric global surgery. Dan is a professor of pediatric surgery at the McGill University and senior scientist at the RI at McGill University Health Center. Here in the master's program in health professional education and international development, a doctorate in health strategy and management, and is very well funded by CIHR and FRQS in patient-centered surgical care. He heads the McGill Commissar Lab and the director of the Jean-Martin Laberge Fellowship in Global Surgery, which has been extremely successful, and the founding member of the Global Initiative for Children's Surgery. He's extremely well published with over 160 scientific papers, some book chapters, and has supervised a multitude of students from undergraduate to master's to PhD students from both Canada and around the world. And currently his main interest is patient-centered surgical care, technology-assisted surgical communication and medical education, and developing global surgery research capacity. And personally, I've always had the pleasure of actually seeing Dan much more outside of Canada and in Africa than across the street here in Montreal, and it's always fun to work with Dan abroad. So I look forward to hearing your talk. I apologize, I'll have to leave halfway through, but the floor is yours.
Thanks, Dan, very much. Yes, we kept meeting in odd places and well outside Canada. So thank you for the opportunity to present this work. It's a little bit of my sort of earlier career. As you can hear, I have changed sort of directions significantly, but still global surgery is very much close to my heart, and we still have several students that continue to do research in this. Don't have any disclosures, although in line with global efforts and equity, I do want to acknowledge that I'm a settler in the Commissar Lab, which is found on unceded Indigenous lands, and I'm very grateful for the opportunity to live here, and hope to become an ally and to help in the process of the reconciliation. What I'll do over the next 40 minutes or so is a very quick sort of parallel biographies, both of myself and the movement of global surgery. Spend most of the time, or a fair bit of the time, on the subject as it was presented in 2015 with the Lancet Commission. Then sort of show us a bit like what's happening nowadays in general, but specifically on the pediatric surgical side, of course, because I'm a pediatric surgeon, and then end up with something that I've added from my previous talks, which are some of the persistent dilemmas in global healthcare, which I hope will be of interest. Yes, so just by around year 2000, I felt called to go to Africa as a white man, as a white surgeon. I call it the white surgeon's burden, reminding us of the white man's burden, which is one of the hallmarks of colonial attitudes to Africa. I came into the footsteps of a general surgeon, Dick Bransford, and a U.S. general surgeon, who right after he finished his general surgery, moved to Africa with his family and practiced there up to for about 30 years. As you can see, 35 years, primarily working with children with surgical disabilities. I arrived in Kenya in 2003, spent the first 10 years or so in Kenya, then a couple of years in Ethiopia, and then I went on sort of short-term stints on a regular basis, or frequent ones, to a couple of countries which were a little bit harder to sort of stay in, like Somaliland and Congo. This was our situation. This is what we've sort of built over the years in Kenya. It's a place about an hour outside Nairobi called Bethany Kids. A large inpatient and outpatient facility with 3 operating rooms, 3 fully trained pediatric surgeons, lots of nurses, therapists, pastoral care workers. Developed a countrywide mobile clinic network for Kenya, which is a bit of a model. And really, it was quite a unique place when I was there. For example, by the late 2000s, we were doing the largest number of hydrocephalus and spina bifida of anywhere in Africa. When I arrived in Kenya, I discovered, to my surprise and shock, something which I call the other pediatric surgery. It just wasn't like anything that I was used to, that I had trained in Canada before. It was a practice which had a very wide spectrum, included urology, plastic surgery, ortho, neurosurgery. Children that presented late, presented with advanced disease, presented with diseases which we hardly saw in Canada, like spina bifida, often malnourished. And the hardest thing was that all neonates, because of course it's a pediatric surgeon, I'm a neonatal surgeon, we love those cases. All of basically the children that were born with those conditions, either they were fatal conditions and then they all died. We never even saw them come to our hospital, or they presented years later with those conditions, but that had become a chronic disability, things like hypospadias or cleft lip and so forth. So this is what at my heydays in Kenya, what my practice looked like. I was doing almost 50% of my work was neuro. It's not, I do not call this neurosurgery because I certainly am not a neurosurgeon. I was doing hydrocephalus and spina bifida cases, that's all. I was doing a fair bit of gastrointestinal, like I should. That's a picture of a child with Hirschsprung's. I was doing a lot of GU, hypospadias, and renal conditions. A fair bit of plastics and ENT, primarily cleft palates and cleft lips. So very different practice than what I had sort of been used to. My response to that huge burden that I saw was, of course, to do. Early on, before I did any research, I called this the disease of the twos. There were just too many children that lived too far, were too poor to reach to any help. Therefore, they arrived to us too late. And even then, there were too few physicians and healthcare professionals to help. So therefore, at the end of the day, too little was done. But I was told, TIA, this is Africa, a statement which I embraced fully, although at this point in time, I'm extremely uncomfortable with. And the solution, again, was, well, anything is better than nothing. Again, an answer which I am, at this point, extremely uncomfortable with. But not at the time. I was doing everything I could. Everywhere I could, I went into refugee camps, into closed countries, anywhere where I could do surgery or see patients and then bring them over. And it was quite exciting. No question, it was quite exciting and obviously a real fun sort of endeavor. Early on, I realized that this was all insanity, that I could not just keep doing like that. We had to teach. My predecessor, Dick Bransford, you see him on the picture on the right, had actually started training informally. The young man you see sitting down with a patient, but it was an informal training which did not give him any paper to practice. So we started quite early on a fellowship training program in pediatric surgery. This was done in a formal way with a formal curriculum, which we actually patterned after the Canadian Royal College curriculum at a time. We did it in partnership with the Pan-African Academy of Physician Surgeons, which was a body that was training surgeons, general surgeons, and with COSEXA, the College of Surgeons of East Central and Southern Africa, which was a very important group for any type of training. And this was right there in our little place in Kenya. We actually opened the first pediatric surgical fellowship training program in East Africa in 2007. We more or less training one fellow a year. By now, as you can see, we have over a dozen of these fellows in 10 different countries, many of these countries being places where there were no pediatric surgeons before. This is an early dated picture. We have many more fellows and thankfully, many more women who are trained, who are graduated in our group. But they did indeed, half of them came from countries that did not have a fully trained pediatric surgeon before. So going away from myself and it's more interesting, the biography of global surgery, I put this together. It's not taken from anywhere. This is how I sort of started seeing what happened basically in global surgery. It started in the 1900s with missionary surgeons and some military surgery. Then mid last century, 1950, the WHO declaration on healthcare and the access to healthcare across the world, of course, sort of opened the way for people to start thinking outside their comfortable high-income country environments. Then half a century later, 1978, you may or may not have heard of the Alma-Ata Declaration, but basically this was the nail in the coffin of global surgery for at least a quarter of a century, because this is the declaration that basically said that what the world, the so-called developing world in those times needs is primary care, not surgery. And that basically all funding went away from surgical efforts. By the 2000s, things started improving again. We had the Millennium Development Goals, and we could easily see surgery fit into those Millennium Development Goals. Médecins Sans Frontières was doing a very good job in surgery. Often they did surgery. The so-called war on HIV/AIDS also included surgical procedures for us. And then it sort of limped along until the explosion in 2015 with the so-called global surgery revolution and the globalist explosion that I'll be talking about more soon. The progression also, you can see it as being from the sort of 1800s missionary and military surgery. In the early 1900s, the concept of tropical surgery came because most of the surgery was done where it was hot in the tropics. And then by the late 1900s, a lot of temporary platforms came about. At the beginning, we had surgical safaris and blitzes and some things which are sort of frowned upon nowadays, but then also much more solid platforms like Mercy Ships, which is still extremely successful today, that has continued and expanded the provision of global surgery. By the 2010s, the focus became, as we're desperately, the surgical community was desperately looking for a way to advocacy and improving resources for surgery, the concept of essential surgical care came. The idea was that certain procedures are more important than others, and that we need to focus on these procedures to save most of the lives and the permanent disability for that, of course. Sounded very good. It was very good, very useful, as you can see. Just leaves a little bit of an uncomfortable afterthought, because basically what essential surgical care for LMIC says is that in high-income countries, we need all surgery. But in low and middle-income countries, we just need some surgeries, just the most important ones, the most serious ones. So then things changed with the global surgery concept and its explosion. And I'll spend a little bit of time about this. The actual, what global surgery is, none of these are actually definitions for global surgery as such. They're medical, but it's the same. The focus in global surgery is not on geography at all. It's on equity. It's about achieving equity in healthcare and, of course, in surgery by whatever means that is possible so that surgical care will be there. So yes, 2015 was the year of global surgery. Started with the Amsterdam Declaration on Essential Surgical Care, which was very important. Then very powerfully, the Disease Control Priorities Series, which had existed for a while globally, for the first time dedicated an entire volume on surgery. 2015. 2015, World Health Assembly Resolution 6815. For the first time in the history of the WHO, surgery was mentioned as such, and the resolution was about surgical care. And then right in the footsteps of that, this was actually choreographed very carefully by the surgical community. The Lancet Commission report came, which had worked for the last 2 years before then. And it focused on, it was called Global Surgery 2030. And this basically is the basic foundational book and source for everybody today that's interested in global surgery. This Lancet Commission came up with some key messages, very striking, powerful messages, big numbers, 5 billion people that don't have access to good surgery or affordable surgery, over 130 million additional procedures each year necessary in LMICs to save lives and prevent disability. Over 30 million people that, if faced with surgery, would be either impoverished or completely destroyed financially in their families. And then a couple of positive messages. First of all, that investing in surgical services is actually affordable. It saved lives, and it actually promotes economic growth. And then a very swapping, very strong statement from the then WHO UN head, that surgery is an indivisible, indispensable part of healthcare. Very different from the Alma Ata Declaration. I'll just unpack a few of these with charts from the Lancet Commission. Surgery is cross-cutting. Most of us know that, all of us should know that, but the world didn't know that even in communicable diseases, in non-communicable diseases, in injuries everywhere, there's no such thing as medical disease. Every one of these areas involves surgery to different percentages, of course, but it does involve. Even nutritional diseases, sometimes nutritional deficiencies, sometimes need surgery. Of course, global access, which is terrible. This is probably the most popular, the top graphic in the Lancet Commission, showing the proportional population without access to surgery. That dark red, of course, is all access, which is sort of in the 70, 60, 70, 80% lack of access to surgery. And of course, very biased geographically. The Lancet Commission also established a term of Bellwether Procedures. It's a very useful term. Basically, it identified 3 operations. They're sort of adult-ish operations: cesarean C-section, open fracture, and laparotomy. And basically decided that if any hospital provides these 3 operations, they can provide most of the essential surgeries, whatever those are. And therefore, access to these hospitals that provide Bellwether procedures is what matters. And you'll see how that is in the statistics in a moment. First of all, in terms of surgical workforce, through a variety of studies, mostly this graph actually compares a number of surgeons, anesthesiologists, and obstetricians, as the so-called SAO providers per 100,000, and compares it to maternal mortality ratio, just as one marker of mortality. And you see that there is a sort of a sweet spot, somewhere, an inflection in the curve, somewhere between 20 to 40 SAO providers per 100,000 that's necessary to keep that mortality ratio to a reasonable sort of 80%, 90% level. What about how many surgeries do we need to keep people well across the world? It's interesting because several of these statistics and correlations, for example, with various types of calculations of surgical rates across various regions, all ended up with a number, a magic number, somewhere around 5,000 surgeries per 100,000. And this is the same number that sort of comes when you want life expectancy to sort of inch towards a reasonable 70, age 70 type number, as opposed to 30, 40, 50, which is frequently encountered in LMICs. Again, the inflection in the curve. Now, of course, in this surgical rate, you see numbers that go all the way to 30,000 operations per 100,000. We're there, US primarily, but also Canada and many countries. But obviously, that's not necessary. And the number is somewhere around 5,000 to 6,000. And then when it came to finances, catastrophic expenditures, huge difference between the high-income countries, which you see sort of at the bottom here, and the low-income countries at the top left, in terms of percentage of the population that gets hit by this. So you can see that in low-income countries, up to 15% of the population will be basically destroyed, families destroyed, any income destroyed, livelihood by one surgery, by just having to have one surgery. While if you go to the high-income countries, of course, it's negligible percentage by and large. Speaking of finances, I love this graph. I'm also grateful I participated in providing the data for it. About what we did is we calculated the cost effectiveness of surgical interventions in dollars per DALYs averted. In other words, how many DALYs do you save by doing the surgery? And we compared surgical procedure, that's the red ones on top, with medical procedures, that's the blue ones at the bottom, only to show for the first time with great satisfaction for us surgeons that actually surgical interventions are not necessarily more expensive than medical interventions, especially if you look at things like beta blockers for ischemic heart disease, ARVs, antiretrovirals for HIV, and so forth. Of course, vaccines are cheap, but most of us don't give vaccines. And I'll show you some of the studies for this specifically. We were looking, for example, at hydrocephalus repair, and we estimated a cost of $100 per DALY averted. And then the positive message that not only that it's effective, that it's cost effective, but that actually, if you don't treat surgical disease, you lose big time in the GDP. And calculations were boldly made to show that up to 2% of the GDP, especially in low-income countries, would be lost. Now, 2% of a country's GDP is huge. So that was very impactful as a message, as an advocacy message, of course. So the Lancet came with these 6 core indicators for universal access to surgical care. Access to bellwethers, here's the bellwethers, within 2 hours. So you had to try to get within 2 hours if you had any bellwether procedure, because that meant that even if you had other operations within 2 hours, if it was urgent, you could get to a hospital that could fix that problem. Specific numbers in terms of SAO, surgery, anesthesia, obstetrics, workforce density, specific numbers of surgical volume, we've seen that. Specific perioperative mortality, that sort of came a bit later. That's what we didn't have studies on that yet. and then protection against both impoverishing and catastrophic expenditures. And these are defined very strictly, what's impoverishing, what's catastrophic in terms of family incomes. What was really elegant is that you can then develop, each country, each region can develop these criteria, these indicators as a dashboard. And you could see where you are and where you are from one year to the next. Just for fun, the first country that put their hand up in that meeting of WHO and said, we want to calculate it for Zambia. And that's their dashboard. And of course, they were failing in every area compared to the indicators that were required. So that was a good example of this applied in action. So that's generally just specifically about Lancet Commission and general global surgery. I'll spend the next 10 minutes or so in just looking at some of the things that we're involved in, and just a bit of a sort of snapshot of what's happening in global surgery. The training prerogative is obviously a huge one, and it's huge because you can see where the maldistribution of healthcare workers by region, and basically all the fat circles, which means lots of global workforce, is in the area with the lowest global burden of disease, and vice versa for Africa and Southeast Asia, sorry. And in this sort of cartoonish world map, it's actually calculated by workforce. You can see that Africa has disappeared, and it's just under the burden of the huge workforce that's available in Europe. Well, they didn't have any data on workforce. We didn't have any data on workforce for pediatric surgery because it was all done for adult surgery or general surgery in general. So there were several papers that we actually worked on to create this. And here's one early paper that we contributed here, where we first looked at and inventoried the number of surgeons, pediatric surgeons, by countries. And of course, you get a similar map with where the red areas, of course, are around Africa. And then we actually did some mean survival case series and tried to identify an ideal sort of pediatric surgeon number per million children, which would make sense based on the data that we had across all income levels. And we actually came with a number of about four pediatric surgeons per million children, which, remember, when you compare to Canadian settings, includes not just pediatric surgeon, pediatric general surgeons, it includes pediatric orthopods, pediatric plastics, and everybody else. The training really got to a very good start in Africa. I'm looking here, this is just a snapshot of Sub-Saharan Africa through two colleges, the College of Surgeons of West Africa and East Africa. The East African came later, but both of them are doing an extremely good job. Rather than having national colleges, which was just not tenable, sustainable, by having regional colleges. In fact, these regional colleges have very high standards for training, for evaluation, for certification, for accreditation of sites, and that's working very well. I'm not going to talk about this here, although I could. Within sort of closer to home for me, I was involved all these years in this Pan-African Academy of Christian Surgeons, and this is just one little group, one little NGO. This is our little sort of more recent sort of card, progress performance card, training programs in 10 countries. There are 22 training programs with over 100 residents in training. Already 135 general surgeons that are graduated across Africa, and basically serving in 20 African countries, which is and they're all embedded within the College of Surgeons of East Central Southern Africa. Close to my heart, of course, is research, and research was indeed the next level aha moment after training for myself in Africa and for many of us. Our early research, which covered much of the past decade, was really unabashedly research for advocacy or research as advocacy. You can see the titles: essential surgery, integral to right to health, an investment in knowledge, a call to action. The papers were so-and-so, the quality of the research was so-and-so, but the message was strong because that's what we wanted to do. We moved past these moments because we don't need to advocate so much, because it's sort of, at least it is known now through the Lancet Commission. So our research has sort of gone a little bit to a better level. This was actually 2017, 2018. This was my cornerstone paper for my PhD. And what I spent a lot of time was actually establishing disability weights for pediatric surgery, because they didn't exist. To calculate something like cost effectiveness, dollars per galley, burden of disease is all about galleys. And galleys, in the formula, you need this magic DW, disability weight. So we actually did this study, and we did it both in Africa, in Kenya, and in Canada, to make sure that we're sort of good with that. And you can see here, these are actual disability weights. They always go between 0 and 1. And there are a bunch of 10, 12 conditions, pediatric surgical condition. We did it by various methods, and we did it in Kenya and Canada. And we actually got these values that can be used now to establish what the burden of disease is. So that was a good paper. It took a year and a half to get it published, because we had to work hard on the methodology for a proper journal, which Population Health Metrics is. Here is a more recent paper on the relation between workforce and outcomes, and this comes from the Boston group. I was part of it, but Fabio was part of this as well, with Paul Trusha as the first author. But basically identifying very, very elegant and nice that the SAO workforce density is, of course, associated directly with the under 5 mortality rate and the neonatal mortality rate. And that if we scale up that surgical workforce to the levels of the Lancet Commission, 20 to 40 SAOs, we can prevent anywhere between 250 and 500,000 under 5 deaths, mortalities annually. And most of these deaths would be neonatal deaths. Then we learned as a community in pediatric surgery, we learned in the late 2010s about the example of the Global Surge Consortium, which was a consortium based in the UK that started doing these massive multiplayer studies with dozens and hundreds of countries and surgeons from all over contributing data to get this global picture. We established our own little thing called the Pediatric Africa Research Collaboration. Not bad. We had 50 hospitals from 20 countries. This was led by Naomi Wright, who's a star global surgeon from UK that I had the opportunity to supervise. And we got data, and we showed, for example, these massive gaps in outcomes. The worst is by far gastroschisis. 75%, 2% mortality in high-income countries, 75% mortality in low-income countries. Nothing to laugh about. It's really to cry. But the same applied to a bunch of other conditions. Majority of these deaths being, again, in neonates and associated with poor systemic condition at presentation and at primary intervention. They came too late, basically. This grew up, and we had last year, we finally managed to publish this data much larger data of the Global Ped Surg Research Collaboration, looking at this time 74 countries, 260 hospitals spread across the income spectrum. And this got in the Lancet. And again, of course, the data is not surprising to us. Massive differences in gastroschisis, diaphragmatic hernia, esophageal atresia in terms of outcomes. And these data were sort of both presented and then interpreted further. But it wasn't just in Africa. This is a separate group that we were involved with, which is the very well-known Brazilian group. Actually, this was before Fabio, which used a lot of geospatial analysis to identify for a middle-income country. Now, it wasn't about bad or low resources. It was about inequitable distribution of resources. And this is a really cool map because I think I can show you just like this, looking at these maps. Red shows areas of the country where there were insufficient workforce for the child mortality, while blue are areas where the opposite happens, where there are too many surgeons for the mortality that was there. And of course, for Brazil, everybody that knows Brazil knows that this is classic. It's global. It's the North had terrible resources and the South had very good resources. And that's exactly what we found in this study and similar studies. All these studies were about burden of disease. But there was a point around in the late 2010s when people started saying, okay, we know it's bad. Don't tell us it's bad. Do something about it. And sort of very, very interestingly, the World Journal of Surgery, which is a landmark journal for this space, stopped accepting papers that described how bad things are in Africa and said, we want implementation studies. And we got started with that. And this is a landmark. This is the first massive implementation study done properly in pediatric surgery. This was the protocol that got accepted in Wellcome Open Research, a very good setting. Again, coming from Naomi Wright, she's the author, and the group at King's College London, and I was involved in this as well, which was actually a very nice implementation study. It was a hybrid effectiveness implementation pre-post study in 7 countries, 7 sites across Sub-Saharan Africa, as you can see. And what Naomi did is she first developed with local partners through a multiple Delphi studies. She developed nominal group processes. She developed these interventional bundles for gastroschisis. And it said very clearly what they're going to do, what these bundles will contain. And then she went and she spent time herself and her team 1 month in each one of these sites and basically changed the whole spectrum of gastroschisis care across Sub-Saharan Africa. I don't have the results yet. I do know the results yet. They are embargoed. This is going to be published in the Lancet and should be coming in the next 6 months out in the Lancet. But it's an example of the type of studies that we need to do. That was about research. Regarding clinical provision of care in terms of surgical platforms, these are the sort of, this is the way that we see this now, is that whatever happens there needs to happen in these very multidisciplinary holistic platforms. We feel that they need to be needs-based, of course, rather than us deciding what we're going to do. They have to have an educational focus. They must be bidirectional. Stuff cannot flow one direction only. It never works well like that. They need to be long-term partnerships and focused on capacity building. I'll share just a couple of slides on the group that I was involved with from the beginning in 2016. We started this group, basically very flat, hierarchy group, grassroots group of providers. We're mostly pediatric surgeons, but we have pediatric nurses and others as well, mostly from LMICs, to identify solutions to the problems in pediatric surgery. Obviously, that's what we wanted to do. We started off very linearly, analyzing the current state of pediatric surgical care in children, developing local and global priorities for improving that, and then trying to figure out where to find the resources to do this work. I'm very excited about the values which we wrote for our group. It was definitely one of those nothing about us without us. From the beginning in our organization, we were more providers from the global south than global north. And each one of our committees, and we have a lot of them, is headed by a provider from the global south. We decided to break away from being just pediatric general surgeons, which most of us here are, and we included all pediatric subspecialty. That's why we call it children's surgical care. And then, yes, very collaborative, very much grassroots, very trainee involved all the time. All of our reports are led by trainees, and very much not much organizational structure, just trying to do the work. Membership only came last year. There was no such thing as membership. You just worked with us. We produced at the beginning, the main document work that we produced in 2017 was this optimal resources for children's surgery, which was a compendium of recommended minimal standards for safe children's care and for safe anesthesia at 4 levels of care: basic, intermediate, complex, and National Children's Hospital. And the idea was, and this is what's happening now, is that as countries are creating their NSOPs, which are the National Surgery, Anesthesia, and Obstetric Plans, we're trying to encourage them very strongly to incorporate this document in their plans. And we have a lot of partnerships, and this is just an example from the website. I just took it out from the website. Different country, many places. The one to highlight probably is Kids OR. It's a great partnership that is just amazing. This UK-based group, led by a millionaire who's got a big heart. Basically, they built with us over 50 operating rooms across Africa and Asia and other areas. And it's basically changed what the operating rooms look in all these settings. Pretty impressive stuff. So that's that. That's all the good, bright sides. I like to finish on a bémol, as we say in French, on a bit of a more challenging and maybe unsettling note about some of the remaining dilemmas in global healthcare. I took this from a talk pre-COVID that I gave to the Canadian Anesthesia Association, and at that point I sort of thought about talking about the elephant in the global surgery room, which was, of course, myself as a white person in Africa. And I called it at the time paternalism. I felt it was just very hard to shake off the paternalism in global surgery. Paternalism had to do with the fact that in this very elegant shared decision-making box in any type of collaborations between the global north and the south, the elephant always tends to be in this left bottom corner, which is the paternalistic side rather than the collaborative side, and the passive for the south, the passive rather than the active side. We knew that this was so. We saw this very well in authorship in research, right? And this is very well known, lots of papers now on this. It's really, when you look at across the spread of global health and global surgery, the authorship is not the way it should be. Show you just one of these trends, and this is nice because it's actually a trend where the graph across time looks at the full line. The black line is just the total number of publications blossomed and mushroomed, of course, in global healthcare. But then you realize that this mushrooming has more to do with the little dots line, which is a non-LMIC first author, in other words, an American or European author, rather than an African author, which grew, but much less. A more recent paper from BMJ Global Health shows the same thing. Number of publications, bang, way up, every year goes up. But that increase has more to do with the red, which is all papers, but very little to do with the authorship in low-income countries. And even there, if you look there, the lowest increase is in the authorship in the first position and in the last position, senior position. Most of it has to do with that. It's called, we actually have a name for it now, for that forgotten middle, where we just stick some low LMIC authors in the middle to just make it look like we're really collaborating when we're not, or we're not the way it should be. All right, that was pre-COVID. This is the hardest part of all. I started asking myself, is it, okay, so it's paternalism, all right, yeah. But is it just paternalism or is it a bit more? Does it have to do maybe with just a tiny tad bit of power and privilege? This lovely illustration comes right from McGill. This is Madhu Pai, the previous global health director, and a real voice globally, a tremendous voice for in the decolonial healthcare. Maybe there's more than just paternalism. Maybe there is racism. Maybe there is patriarchy. Maybe there's a bit of a foreign gaze. There's definitely colonialism or coloniality. Maybe there's some white supremacy and a bit of a saviorism where we want to save the global South, and a bit of bunch of lack of EDI. Well, so it's only in the last couple of years that this conversation has really been happening, and we have the first surgical papers that talk about this in exploring global surgery through a neocolonial lens. This is Robin Petrozzi, our own fellow that graduated a few years back. There is thoughts about also we have Madhu Pai here. We have Fabio, our own fellow, that has written on this, on a paper which I was not an author on, and I really resented that, and it had a very good reason why. What is it all about? Well, here's one standard definition of colonialism: economic, social, and political system that relies on the principle of cultural hierarchy and supremacy as a justification for the multifaceted domination of the other. Pretty strong, eh? Decolonizing global health, again from Madhu Pai, 2020 Lancet, is removing all forms of supremacy within all spaces of global health practice, within countries, between countries, and at the global health level. What does that mean? Well, it means some hard and unsettling things. How do we dismantle this? It means moving from a bunch of, unfortunately, colonial ideas which were simply naturalized as global health, to actually disrupting specific legacies of colonialism in our healthcare. It means moving from the so-called, sorry for the big words, coloniality of knowledge, which basically means that what we know in America and Europe is good and everything else is not so good, is less good. to plurality and diversity of knowledge, including indigenous knowledge as well as local knowledge in all these countries. It also ultimately means not just helping the poor in Africa through surgery, but refusing to normalize economic injustices, even refusing to normalize the term that I've used in my talk, the north-south binary, global binary. Instead, moving to global solidarity work and a commitment to eliminate oppressive systems. In other words, global work where we all work together and stuff happens in both directions, and it's not one that leads the other. And also dealing with a very rough question of who is decolonizing whom. That's the question of me not being an author on Fabio's paper about decolonizing. It's not me that needs to decolonize, but I need to be an ally in that process. Here's an example of what this looks like. And this is from Canada, from BC, a recent paper in Canadian Journal of Surgery, looking at partnerships. And we Canadians are really good with this. And we pride ourselves to be very, very forward and progressive and so forth. Here's the percentage of partnerships that were reviewed, and there were hundreds of them, that in terms of things such as community engagement, multidisciplinary collaboration, all of these having less than 50% of the groups actually include that. Worst of all, of course, is community engagement, and worst of all is multi-source funding. As long as all funding comes from the global north, excuse me the expression, then it's not gonna go well. Because whatever expression you have in your language, whoever pays gets to play the game. That's it. That's some final thoughts in terms of global surgery as I see it personally today. I'm very excited that global surgery has become in 2022 a reality, a new reality, both in science and in practice of surgery. Thankfully, we've created a strong, solid scientific framework and even an academic milieu. For the first time, students and residents who are interested in global surgery can look forward to having a successful academic career in the project, in this field. It's definitely expanding very rapidly, lots of partnerships, lots of training programs, and lots of research. And from the beginning, global surgery was deeply rooted in ethics of social justice and health equity. But unfortunately, it still struggles a bit with some issues, which I've outlined before. So thank you very much. Look forward to seeing you there in that space. Or maybe not. Maybe just without me there. Thank you.
Thank you very much, Professor Poenaru. That was really inspiring. Thank you. It's really wonderful. So any questions, please just unmute and ask or put your finger up. Fabio? Fabio?
I'm just want to say a really beautiful presentation. We have a special guest here that listened to your talk carefully. Thank you,
Fabio. Thank you, Fabio.
So I was under the impression, and thank you very much for the education about global surgery, because I thought global surgery referred to surgery within geographical boundaries. And so I thought it has to do with low-income countries, middle-income countries. So what's the global in global surgery? What does it refer to?
Very good question. Thanks, Faxon. Yeah, initially it was international surgery. We talked about international surgery. At this point in time, we refer that term to purely geographic surgery. In other words, I go somewhere else because they may want to know something, or I have friends in that country and we do surgery in those places. global surgery is not geographic, but it is about, it is very much entrenched in geographic disparities in income. So it is about low income, middle income, high income countries. All the graphs, the charts that I had those groupings there. That is global surgery, but it doesn't need to be geographic. And as an example of it, in many organizations, at least in ours, Sharif knows so well, in CAPS, we in the Canadian Association of Pediatric Surgery, we include indigenous concerns within global surgery because we know that many of the problems that I've shown you can be replicated in our northern Quebec. And therefore, it's not about geography. It's also in the US. This is increasingly being seen, inner city and rural, particularly rural US, terrible access to care compared to other places.
Okay.
Yes, Sharif, if it's okay, Faxon, Sharif wants to make a comment there. And
sorry, I have to meet with a student at 2 o'clock. So thanks, Dan. I mean, you really touched on so many of the issues that are really struggles. And of course, in your case, you lived this and you've seen it actually develop and you were part of it. I just want to make a couple of comments. So, often when we are talking about kind of global surgical experiences or involvement, we like this binary, categorization of teaching somebody to fish versus giving them a fish. And as easy as that is, I really truly believe that we need to move away from that. And Mark Schreim just wrote a beautiful piece. He's a surgeon who's also been working very closely with John Mira in global surgery for a long time, and really wrote a beautiful piece about this false dichotomy, because many of the things you talked about, I was 6 years old when my parents moved to Nigeria as physicians. And when I returned to Tanzania and Kenya almost 30 years later, I could have been there yesterday. Very little had changed. And so if we keep hoping that we're going to change the infrastructure and the economy and the corruption and the, all of the things, hundreds of thousands of people will die in the meantime. And we cannot save those hundreds of thousands of people, but we can save some. And for each person who's saved, that's an entire life, an entire family that celebrates that saving. So I think we just need to pull back a bit from this dichotomy that if you're not capacity building and if you're not, teaching people to take care of themselves, then don't do anything at all, which I'm not, I know you're not saying that at all, but it is taking hold a bit. And I really push back against that. So that's just one of the biases I have. The other is, we are at a time in society where we write a lot, we come up with new vocabulary, we come up with new statements, we label, but sometimes it's not really, doesn't meet our intentions. And, as I hear you speaking about some of the organizations, let's take PACS, I mean, you can take PACS, a group of Western surgeons, mostly American, some Canadian, some from other places, who went to Africa, started residency programs, built residency programs and training programs very much structured around Western curricula, although the nature of the practice was different. And you can call them colonialists and you can call them racist. And you can, a lot of these things can actually apply to a group like that. But I think they've changed the course of training in pediatric surgery and general surgery and other specialties in Africa and have really made a difference to hundreds of thousands. So I think we should just be a bit careful about how we use our vocabulary, and especially for people who actually don't have their hand in the fire and often write and talk about it from remotely. You just have to cross the ocean and be in the shoes of a family that's seeing their child die. And, Fabio had seen this in Liberia. He had seen it with me in many places. And I think you would look at some of this literature that's coming out and have a very different view on it. So that's just the commentary that I wanted to make.
Thank you, Sheriff. Just to mention that actually, I think that the fruit is from the individuals themselves. What we've actually created, if you look at that same organization, PACS, currently 3/4 of the educators are African. So probably if an organization starts off, of course it starts off with whoever is there, but having an attitude that ensures that we build capacity so that ultimately the trainers and the programs are the locals themselves, that actually brings a little bit of the fish bit in, and therefore allows it to continue. And the fishing part, the education part, is absolutely just one of the 3 spheres in which we work. And when I meant holistic platforms, I mean platforms which include clinical care, research, and education. I think that that often works the best. And I think that in your own, even if you look at Mercy Ships, that's what Mercy Ships does now. It does clinical care, but it's building education right around it, and it's building and actually research as well right around that. I think that it's just that there's no place for where a person just goes, does a surgery, runs away after a blitz, or goes there, teaches for a week sometimes with their North American understanding of disease and so forth. That's the stuff that we don't want to see.
Any other questions? Yes, Bilal.
Hi, thank you for your talk. Actually, I'm a neurosurgeon, and I'm here in Canada doing my fellowship in spine surgery, and I hope to participate soon in a global surgery field in spine surgery, especially. Actually, I just wanted to comment on the neocolonialism part. Actually, I think that surgery itself is a patriarchal domain. So even let's say during the residency, during the fellowships, the one who has the knowledge is the one who will be the last author. He is the one who will be the most important person in the room, who will dictate what things to do and what things not to do. So I think this will make, especially in surgery, that this part of liberating global surgery from this colonialism a bit more difficult, because actually this is a little bit confounded with the patriarchal aspect of surgery and surgical training. I don't know what do you think about this this point. Thank you.
Thank you. Thanks, Bilal. If you're talking about patriarchal as in male-dominated, definitely, or if you talk about it as white-dominated, I think that I don't think surgery is necessarily unique in anything else. It's all these specialties were white-dominated and male-dominated, and the path forward is by stepping on it. And we have currently at McGill, we started with a medical school that has at least 50% women and large numbers of non-white ethnic groups. That slowly permeates into our surgical programs, where there's an increasing number of both of these disenfranchised or marginalized groups. And ultimately, the professor, the final author, becomes that person. I was very encouraged when I was in Africa, in Kenya. I remember Kenya, within Sub-Saharan Africa, Kenya is doing very well. It's one of the top. And I remember visiting the university department of surgery, being invited to be whatever associate professor there, and I was the only white person. Already by 2010, Kenya had completely decolonized its top academic department of surgery. All the papers were written by senior authors who were African. And they kept me in my place very well, by the way. So I think that we're in the right track. I think it's just going to take time. And we need to keep chipping at it, I think. It's people like you, it's everybody on this call, Zoom call, the young generation that of surgeons or researchers that will continue to say that and to believe in it and to put it forward, that eventually is going to percolate to that senior author.
Thank you.
Yeah, I liked the way you started training local people to try to take over and be able to manage the care in their own backyard, because there has to be an exit strategy, you know, and because as you said, as you know, as you are going from place to place, you could see that you couldn't manage all of the, you know, and so one thing about how does one do a follow-up? For example, if it's a cleft palate, you have to come back. How does one do a follow-up in such a case? I mean, I was born in Zambia, and I knew the problems that were there. That was, you know, 30 years ago. So how does one do a follow-up in your case if you're alone and there's certain that need follow-ups? Mm-hmm. Or they may need a patient to have sufficient nutrition for you to do the surgery. How does one do those kind of situations?
Yeah, that's actually that was always historically one of the key issues with itinerant surgery, where you go in, go out, and then leave the patients behind. Early on, and by early I mean 20, 30 years ago, we've made it clear that that is absolutely bad surgery, that is unacceptable surgery, and there has to be a follow-up system. But it was possible. It was not that difficult, because as long as you don't work as a Lone Ranger cowboy in your surgical blitz, as long as you work with the people in your community where you go, and I'm talking about as a pediatric surgeon, I would go into a hospital that can do pediatric surgery. Well, there were general surgeons there. They may not have been pediatric surgeons, but they were general surgeons. And we make sure that we train and that we advise in such a way that this follow-up can be done. So I'm not the one back in Canada trying to figure out how my patient is doing from last week. They're being rounded on and seen, and we always clarified how often they need to be seen. And then if that surgeon, or maybe mid-level provider, if there's no surgeon there, would connect with us by WhatsApp or email immediately. If there was a question, a problem, they would send us a picture and so forth. That's how most people do it when you are stuck in a mobile platform. I know, for example, again, Dr. Mills' Mercy Ships, which he's involved with, that was a concern early on, but they exactly addressed this in the same way, because they have collaboration with at least some local providers who will then continue to follow up the patients.
Thank you very much. Any other questions? Mike, you look like you have a great...
Dr. Poenaru. Wonderful presentation. I really enjoyed it, and very educational. A lot of things I obviously didn't know. This was just definitely enlightened me. I had a question more related to the political situation in these countries. So how does that affect, let's say, your global surgery programs in terms of acquiring money or funding? And how would that impede like a smooth decolonialization strategy?
Well, that's good. Especially the second part got me thinking. I thought it'll be easy to answer the question until you put the second part of it. No, there's no question that is a reality. But it cuts two ways. It actually thankfully cuts two ways. On one side, yes, if you have an insurrection and rebellion and civil war and so forth, then all the people, all the well-meaning white people leave right away, which I did at times when there were issues in some of the countries where I was. But actually, it was good for those countries because those countries realized that they can do it themselves. They were forced to do it themselves because all the whites disappeared. A perfect example at point. I am still by name the dean of a medical school in Congo. I'm only the dean because for them to be accredited as a medical school in Congo, they need to have, in DRC, they needed to have a PhD as the dean. And until they find a PhD, I'm the one. But I was actually there much more than by name, 3 times a year for several years, spending time doing the thing. And then COVID came. And in fact, it hit exactly the moment, the day when I was just on my way back through Uganda to DRC. And then I was called immediately back because my team needed me here at McGill. And I haven't been back since. And guess what? They're doing very well without their white dean. I'm still their dean on paper because I'm the PhD, but they've stopped even asking me questions about the curriculum and the teaching and stuff like this. They know that I'm less interested, but I know that they can do it themselves. So maybe that part of it is not a bad thing. And the same thing we saw, not just me, we all saw this during COVID with global surgery. We saw 2 things. We saw that it's a good opportunity for the local team to rise up and to take it themselves. And B, we saw that we can actually do a lot of stuff by distance. And of course, we know that in all countries. So yeah.
So
thanks, by the way,
wonderful
for
examples.
the nice smile. It kept me going through the whole talk. I tend to get bored and tired of my own talks, but seeing your face smiling, it really helped me.
Well, thank you.
So thank you very much, Professor Poenaru, for that really wonderful talk. I think we need people like you to help set a new course for equity and also being able to have open dialogue. That's important because we know that there are things that have been created in the past that still follow us, and if we ignore the elephant in the room, it will always be there. So thank you very much.
My pleasure.
Thank you everyone for coming.
Bye-bye.
Bye.
Yeah, thank you very much.